Good evening, everybody. Welcome to part two of this webinar series. This webinar is regarding reasonable and necessary services for home health. If you have not yet listened to our first webinar on the face-to-face encounter and homebound, please make sure and do so, as that will give you even more insight as to what CMS is requiring for home health patients. So today, for reasonable and necessary, I'm going to go through these slides a little bit quicker, so we won't read each and every one of them. Hopefully you guys have a outline already printed for you so you can follow along and keep these for your future use. But basically we're going to go through what is covered by Medicare, i.e. Medicare Advantage plans when it comes to home health services for skilled nursing and therapy, as well as social worker and home health aides. We'll also touch just quickly on routine and non-routine supplies that are covered under the home health benefit. All right, so covered services. A qualifying home health plan of care includes part-time or intermittent skilled nursing care other than solely for venipuncture for the purpose of obtaining a blood sample. It also covers physical therapy, speech and language pathology, occupational therapy, a home health aide, medical social services, and medical supplies. So those are all covered under the home health benefit. You just have to meet the requirements and follow the guidelines as far as documentation to ensure payment for these. Intermittent services, if you're not aware, is considered less than 8 hours each day and 28 or fewer hours each week to be considered intermittent skilled care. So make sure that your patient is not requiring a more intensive service, which would not be covered under the home health benefit. So why home health and why now? That should be the question everybody asks themselves when asking if a patient qualifies for home health services. So why home health and why now? Is there a new diagnosis? Is there an exacerbation of a chronic illness? Has the patient had a recent hospitalization? Have there been new or changed medications or treatments? Is there a current infection requiring antibiotic therapy? Does the patient have a wound that requires skilled wound care? For our therapy services, is there a decline in function, a decline in the ability to perform the ADLs, or a change in speech or swallowing? This is what you need to ask yourself for every patient to determine whether they qualify for home health care. If a patient does not meet one of these requirements, then they likely do not qualify for home health service and they are not appropriate to admit to home health services. So when you're looking at your referrals or you're out doing an assessment of a patient, you need to be looking at this list and asking yourself if your patient meets any of these why home health and why now questions. This should be your first and foremost go-to for determining medical necessity. So when you're looking at whether you admit a patient, what are the admission requirements? Well, first you have to have an order for the skilled services, and you have to have an order required for each discipline that's planning to evaluate the patient. So if your order simply says home health, evaluate, and treat, that is saying you have an order for a skilled nurse to evaluate. And if you want additional disciplines, the nurse would then have to call and get verbal orders for therapy services or for a home health aide. So make sure before you send out any therapists or any other disciplines to evaluate the patient that you have orders to do so. You also have to have a face-to-face encounter. Now, that's why I say make sure and listen to the previous webinar on face-to-faces, but you need to ensure you have a face-to-face encounter that's compliant and that documents what those new or changed needs are. So what are the new diagnoses? What are the new or changed medications or treatments? Why home health and why now? When you're looking at the requirements for a face-to-face, just a couple quick tips. It has to be from an allowed provider, which is an inpatient facility doctor, nurse practitioner, physician assistant in an inpatient setting, or it has to be performed by the certifying physician, which is the physician signing your plan of care. The face-to-face has to be within the allowed time frame, so 90 days prior to start of care or 30 days after. And the face-to-face encounter has to be related to the reason for home health. So your physician is guiding you as far as why home health and why now. And so those are your orders. That's why you're evaluating that patient, is for whatever that face-to-face elaborates on and documents as the reason for home health services. The home health benefit requirements must be met, which is that the patient is homebound. And again, our previous webinar goes over homebound, and you have to have a physician that's willing to oversee the plan of care. So you need to know going in who's signing your plan of care and what services are they willing to oversee or order for this patient. Finally, the skilled needs identified at the time of the assessment. The patient has to have some identified needs, and these have to be based on the Medicare benefit policy, which is the purpose of this webinar today. Again, intermittent services only, and any other disciplines that you order have to be justified based on your assessment. Just because you have an order for nursing, PT, OT, ST, home health aid, and MSW does not mean that the patient qualifies for all of those services based on your assessment. A lot of times we get generic orders that come over for all of these service lines, and the patient just simply doesn't qualify for physical therapy, or they don't need a home health aid. So you need to make sure before you put orders in or schedule out an evaluation for any other disciplines that they're justified based off of the assessment that's being conducted. Looking at your plan of care, you need to remember that everything has to coincide. Everything flows, and everything flows from the face-to-face. The face-to-face encounter, again, documents the reason for home health, and why now. Your coding should reflect those treatment needs that are identified in your face-to-face. So if your face-to-face has to do with COPD and there was an exacerbation of COPD, but say the patient also has diabetes, but there's been no new or changed or exacerbation of diabetes, then your coding needs to reflect the true need of home health, which is your COPD. And then in turn, your plan of care, which is your interventions and goals, has to follow suit. So again, if your face-to-face is COPD, you code COPD, then your interventions and goals should reflect respiratory interventions to monitor, treat, educate, whatever it may be for COPD, and not on the diabetes that has no new or changed interventions or treatments. So make sure that you have a clear understanding of what your face-to-face focus of care is, what your coding is, and then that your interventions and goals align with all of that. If you're finding an unalignment or they're not cohesive, then you need to go back to your coder or your quality assurance nurse, and you guys need to work together to ensure that your plan of care reflects the need for home health that's identified. All right, so moving quickly into skilled nursing, what's covered? So basically think about it like this. To be considered a skilled service, the service must be so inherently complex that it can be safely and effectively performed only by or under the supervision of a professional or technical personnel as provided by regulation. So basically, it's an inherent skill that nursing has to do. So you wouldn't trust the patient to do this. You wouldn't trust a caregiver to do this. There has to be something complex about the skill that's being performed, that only a nurse has this knowledge or only a nurse has these skills to provide this type of care. Non-covered services, make sure that if you're teaching a caregiver a skilled service and they demonstrate that they are able to safely and effectively perform that service, it is no longer skilled. If, though, perhaps there's no caregiver available, that's a different story, okay? But the unavailability of a competent person to provide that service, regardless of the importance, doesn't make it skilled. So say your patient needs to have their toenails clipped. They're diabetic. It's a skilled need. Nursing or a podiatrist needs to be the one that does this. There's no caregiver in the home to perform it. Well, just because it's something the patient needs doesn't make it skilled. Just because the patient doesn't have anybody in the home to do it doesn't make it skilled. Cutting toenails is not considered a complex skill that a registered nurse has to do. So make sure you understand the difference between a skilled service and a non-skilled service. And no matter what the circumstances, a non-skilled service cannot be considered billable through Medicare just because a caregiver is not available. So those covered services, a condition of the patient may cause a service that would ordinarily be considered unskilled to be a skilled service in certain circumstances. So if by nature it requires the skills of a nurse to be provided, even if it is taught to the patient or the caregiver, if it's still a skill that that nurse needs to oversee, then it remains a billable skill. So really, get into the Medicare benefit policy, which is where all this information comes from, and make sure that you understand the difference between the skilled and the unskilled service. So documentation of a skilled service. This is straight out of the benefits manual. It's expected that the home health record will reflect every visit the need for the skilled medical care provided. So why does a nurse have to be the one to do this? And that has to be recorded every single visit. Within that documentation, you need to have details of the skilled services that were applied. You need to show the patient or the caregiver's response to those services and what the plan for the next visit is based off of how your visit went. There also needs to be a detailed rationale that explains the need for the service. So, whether it's no caregiver available, whether it's the patient's unable to reach their feet to do wound care on the toe, why does it require a nurse to do it? And finally, what's the complexity of the service being performed? Why is it skilled? Are you having to irrigate a wound with medicated solution? Are you having to insert a Foley catheter that requires a nurse to do it? What's so complex about this that it requires a nurse to go into the home to provide this service? So when you're documenting that medical necessity, which is what you're doing within your notes, these are some templates to think about as far as how you can better document the medical necessity for what you're providing. So read through these and perhaps use these when you're documenting the skilled needs that you're providing. So when you're documenting the response to treatment, the biggest thing I want to point out from this slide is to not use these highlighted terms. Do not say the patient tolerated it well. Do not say the caregiver was instructed on medications. Do not say continue with the plan of care. You have to get more detailed on what the response is. Did the patient, complain of pain of 0 out of 10? That's tolerating it well, but we're providing more details. Did the caregiver return demonstrate how to do something? Did the patient verbalize 3 out of 5 signs and symptoms that you taught them? You need to be providing specific feedback on how that patient responds to the treatment that you have provided, whether that be you're performing a skill, you're educating, you're assessing, how are they tolerating all of that? So there's quite a few examples throughout this slideshow that I'm not really going to go through unless one just really sticks out to me. But these are some good examples to read through as you're reviewing your outline. So this is a good one that I like. A patient with a well-established colostomy does not have any complications, but may require assistance in changing the bag because they can't do it themselves and there's no one else in the home to assist them. So notwithstanding the need for the routine colostomy care, changing the colostomy bag does not become a skilled nursing service just because a nurse can do it or does it, immediately post-op. And it can't be a skill just because there's nobody else in the home to do it. So, those are the types of patients that we want to do everything in our power to help them. And we know that they need help in the home. We know there's nobody there to assist them, but we simply can't bill Medicare for services like this because it does not require the skills of a nurse to change a colostomy bag. All right, observation assessment is probably in the, probably 50% of what we see patients for. So observation assessment of a patient's condition is reasonable and necessary when there is a reasonable potential for change. So that means there may possibly come a time when there's a need for modification of treatment or initiation of additional medical procedures in order to stabilize a patient's condition. So there has to be that potential for change. You cannot go out to observe a patient that has been out of the hospital for 4 weeks, but was diagnosed with an exacerbation of COPD. There is not that reasonable expectation that after 4 weeks, you're going to still see a need to modify treatment. Skilled observation services are only covered for 3 weeks as long as there remains a reasonable potential for complications, but it will not cover that after 3 weeks as long as nothing has changed. So when you're looking at going out and monitoring a patient for I keep hitting on COPD, you're going out there to monitor for an exacerbation. After 3 weeks of observing that patient and not coming across any change, any, further exacerbation, any treatment change, any changed medications, then it is no longer considered reasonable and necessary for a nurse to observe that patient in the home. So 3 weeks really needs to stick into your minds as far as 3 weeks for observation and assessment. After that, it is no longer considered a skill. Observation by a nurse is not reasonable and necessary if those fluctuating signs and symptoms are part of a long-standing condition that has not previously required a change in treatment. So you have those patients that go through spells of increased shortness of breath with COPD. But if we've monitored them and their physician has not made any changes and they just know they're going to continue to have these little exacerbations of shortness of breath, but we're not changing treatment, we cannot keep them on service to continue to observe them because there has not been a change in the treatment. So again, a couple examples that I'm not going to go into, but I am going to discuss our frequencies. So we just kind of talked about that 3-week time frame. So first and foremost, we want to make sure, especially for patients coming out of a hospital, that we're front loading our visits. That means we're seeing them more frequently immediately after their hospitalization. But we also have to keep in mind we've got 3 weeks for observation, assessment, and education. So when we think of that, the preferred frequency for these types of patients is 3 times a week for the first week and 2 times a week for 2 weeks. That gets us a total of 7 nursing visits, and we're in there for the time frame allowed, which is 3 weeks. So this allows us to front load and see them 3 times a week that first week to make sure that they're stable as far as coming home from the hospital. But it also prevents us from a LUPA. It also avoids the 5 to 6 visit red flag that CMS monitors on our pepper scores. So we want to avoid LUPAs, obviously, if possible, and we also want to avoid that 5 to 6 visit red flag. So our preferred frequency for these observation, assessment, and education patients should be 3-week 1, 2-week 2 if possible. The other thing that CMS says in the benefit manual is that catheter changes are routinely only required to be performed monthly. So if you have orders to do more than a monthly cath change, that has to be justified with documentation from the physician as far as why. Are we having to change it more frequently because there's frequent UTIs, because it clogs up a lot? Why are we having to go out there more often? Now, this doesn't include those PRN visits, for complications that just happen occasionally. But we should not see, if our only skill in a home is to change a catheter, we should not see every other week visits, for a monthly catheter change. So keep an eye on that. Another thing we should not see is 1 time a week visits. When CMS and auditors see that you're only seeing that patient 1 time a week, it questions the medical necessity for that visit. If you're only seeing them 1 time a week, really what good are you doing? We've got 3 weeks for observation, assessment, and education. Why would you only see them 1 time a week? So it's a red flag when you're just doing 1 time a week visits, that those visits may not be actually medically necessary. Finally, when you're thinking in terms of your frequency, is there a willing and able caregiver to perform the skill? If there's not, and you're seeing that patient more frequently because there's nobody else in the home to do wound care or to monitor for some of this, then you have to provide that supporting documentation as far as the support system that the patient has at home. Management and evaluation of the care plan is something we really don't see a whole lot in home health, so I'm really not going to go into that, but the information is there if you're interested. Teaching and training is the other big thing we do in home health. So teaching and training activities are appropriate to the patient if those activities have to do with some sort of illness, injury, or functional loss. So there has to be something that we're treating. We can't just, go provide diabetes education on a patient that's had diabetes for 10 years and has not had any treatment changes. We can't just reteach on CHF, because the patient, had a little bit of a weight gain, but there hasn't been a treatment change. So it has to be appropriate to their illness, injury, or functional loss. Reteaching or retraining can be appropriate in certain circumstances, but it has to be related to a change in the procedure or the patient's condition. So we cannot see visits where we're teaching fall precautions every single visit and nothing else. We can't teach on COPD signs and symptoms for 3 repeated visits. There has to be some planning that goes in to these visits, and you have to ensure that you're not repeating that education, because according to CMS, that is not reasonable and necessary to repeat education if there has not been a change in the treatment or the patient's condition that requires that retraining. So here, I'm not going to go through each of these, but I've kind of highlighted teaching and training skills that CMS has specifically put into the benefit policy that are covered. So teaching on self-administration of injectables, a newly diagnosed diabetic, self-administration of a medical gas, wound care, a new ostomy, self-catheters, G-tube feedings or enteral feedings, maintenance of IV lines, special techniques and adaptive devices that are required to allow the patient to perform their activities of daily living. So we're getting into some therapy stuff here as well. Transfer techniques, body alignment, ambulation with an assistive device, prosthetic care. So these can all be skills of the nurse to teach and train if therapy is not in the home as well. If you've got physical therapy, occupational therapy out there, then these teaching and training skills would be under their core responsibility and should not be listed as billable skills for the nurse. So these teaching and training skills listed here, when it comes to the ADLs and the functional limitations, are there and considered billable only if therapy is not in the home. Teaching proper administration of oral medications, teaching of a therapeutic diet, dressing or skin treatments are all considered appropriate teaching and training skills. But again, remember your 3-week duration. Again, a couple examples that I'm not going to go deep into, but I would like everybody to review those on your slides. Administration of medications. CMS only identifies 2 medications that are considered billable for administration, and that's vitamin B12 and insulin. Now, there are some specific criteria here, so make sure you're looking at those. If you're administering B12, then we should see specific anemia diagnosis of either pernicious anemia, megaloblastic anemia, macrocytic anemia, or fish tapeworm anemia. One of those diagnoses need to be present in order to justify the patient needing vitamin B12. For insulin, this is for patients that either physically or mentally are unable to self-inject and there's no other person in the home to assist. Pre-filling of syringes of the insulin does not require the skills of a licensed nurse, and therefore pre-filling syringes is not considered a reasonable and necessary service for nursing. That's a big one to keep in mind. We cannot go out with the sole intention of the only skill we're doing is pre-filling syringes, because it is not covered. The administration of oral medications by a nurse is not reasonable and necessary. Again, we can't go out just to give oral meds, and we can't go out just to give eye drops or to apply topical ointments. Tube feedings and replacement or adjustment of those tubes are considered nursing services that are skilled, and if the feedings are required to treat a patient's illness or injury, the feedings and replacement or adjustment of the tubes would be covered. Aspiration or suctioning of a nasopharyngeal or a tracheostomy are considered skilled nursing services. Insertion and sterile irrigation and replacement of catheters. Again, here they specify that is considered a 30-day frequency. So, they're saying that it's unlikely that patients would require this to be done more than every 30 days. If there are complications, you can provide those PRN visits with adequate documentation, but make sure if you are that you're very well documenting why you were called out there. But again, those are as needed. Those are occasional complications. We cannot schedule patients out for more than every 30-day catheter changes without some specific documentation from the physician. Wound care gets a little bit more tricky. So care of wounds obviously is considered a skilled service. We're going to get into some of the requirements, but one of the biggest ones here is when you are assessing that wound, there has to be documentation on admission of the size, depth, the drainage, and the condition appearance of the skin surrounding the wound in that documentation. That should be present in your OASIS documentation in order to justify the skilled need. In addition, the plan of care has to contain specific instructions for treatment of the wound. Now, what kind of wounds are considered skilled? So open wounds that are draining purulent or colored exudate or have a foul odor, or if the patient is receiving antibiotic therapy for a wound infection, those are considered skilled dressings. Wounds with a drain or T-tube, which require shortening or movement of the drain. Wounds that require irrigation or installation of a sterile cleansing or medicated solution into several layers of tissue. Recently debrided ulcers. Pressure sores with partial tissue loss with signs of infection, or ulcers with full thickness tissue loss. So one thing that really sticks out here that everybody needs to take note of is stage 1 pressure ulcers are not considered a skilled dressing. So putting a Duoderm on a stage 1 is not considered a skill. There has to be partial tissue loss with signs of infection, or there has to be full thickness tissue loss. Now, full thickness, remember, involves exposure of fat or invasion of other tissue such as muscle or bone. So you really need to pay close attention with your patients that have stage 1 or even possibly stage 2. If your stage 2 is without signs of infection, they're really not calling that a skilled wound care. So that's something you need to look really close at and what kind of wound care you're providing. But, stage 1 and stage 2 D-cubes are not covered by Medicare guidelines for a skilled wound care. Wounds with exposed internal vessels or a mass of some sort are covered. Wounds resulting from radiation therapy. Postoperative wounds where there's complications such as infection or an allergic reaction, or if there is an underlying disease that has a reasonable potential to adversely affect healing, such as diabetes. 3rd degree and 2nd degree burns, an application of nitrogen mustard or another chemotherapeutic medication would be considered skilled wound care. Make sure and review all of those very closely and that we're following those guidelines when it comes to ordering wound care and putting nursing in a home for wound care, especially when it comes to those decubitus ulcers. Ostomy care during the postoperative period and in the presence of complications is covered. Teaching ostomy care does remain a skilled nursing covered benefit regardless of the presence of complications. So this is referring to you are only covered to perform ostomy care if there is the presence of complications and in the immediate postoperative period. Venipuncture is no longer allowed to be the sole reason for home health eligibility. There has to be another qualified skilled service being provided. Excuse me. So it doesn't mean you can't do it. You can still provide venipuncture, INR monitoring, so on and so forth, but it has to be associated with another skill. So make sure we're not going out there for the sole purpose of venipuncture or INR monitoring. Now, when you do have orders for venipuncture, need to make sure that within that order there is documentation of the associated symptom or diagnosis and that there is rationale for the blood draw as well as results being documented within the home health record. So make sure and look at your order for the associated diagnosis and also make sure that you are getting those results filed within the home health record. Psychiatric evaluations are covered if you are actively treating a patient and it's being done by a psychiatric trained nurse. So make sure you review that. All right, moving straight into therapy services. So when we consider what's skilled therapy, it has to be related to an illness or an injury, and it has to be excuse me, it has to be focused on the restoration or maintenance of function affected by that illness or injury. So, when you're going out and those therapists are doing those evaluations, you need to make sure that there's something that's associated with this. What caused the patient to decline? What caused the change in function? But you also have to ensure medical safety. So a lot of skilled therapy services are based off of ensuring that the patient is safe to perform some of these activities and exercises. So when you're doing your assessment, you need to make sure that you're assessing based off what the patient is safe to do. I see a lot of therapy evaluations where there's documentation that the patient is modified independent walking with their walker for 50 feet. Well, if they're modified independent, where's the skilled need of the therapist? You need to document based off what the patient is safe to do. So if while that patient was walking, you had to hold their arm, that's minimal assist or contact guard, possibly, depending on the amount of assistance you provided. If you had to provide them verbal cues during that, that's still not modified independent. You have to justify that need for skilled therapy based off of what the patient is not only able to do, but what you as a qualified therapist are recommending based off of the safety of the patient. So there also has to be the expectation of restorative potential. So it doesn't necessarily mean that just because a patient doesn't have, the best rehab potential, that doesn't disqualify, but there has to be some sort of restorative potential that's documented. Improvement is evidenced by objective successive measurements. So make sure on your evaluations that you are obtaining objective measurements as far as tug scores, Tonetti scores, pulse ox to show, endurance, things that can later be reflected upon and show progress with those measurements. So this is a big one here. Therapy is not considered reasonable and necessary if the patient's expected restorative potential would be insignificant in relation to the extent and duration of therapy services required. So if you go into this knowing, okay, me providing 3 weeks of therapy services is not going to really make that big of an impact for this patient, or this patient would require daily visits for 2 months to see any potential. You need to go into it knowing what's the significance of that. Therapy is not required to affect improvement or restoration of function where a patient suffers a transient or easily reversible loss of function. And they're very specific here, such as temporary weakness following surgery. This, in CMS's eyes, the patient is expected that they would improve spontaneously as they gradually resume their normal activities. So, therapy in these cases is not considered reasonable and necessary. The expectation is that patient would probably resume their normal activity given time. So really make sure when you're developing a plan of care or evaluating a patient that it's not one of these easily reversible loss of function situations. So documenting medical necessity, I've also provided some little templates here that you can use to justify skilled services. So keep those on hand. Reevaluations, again, make sure those are done every 30 days and make sure you're using objective measurements when you're reevaluating. So, how has the patient progressed on their tug score? How have they progressed on their Tonetti score? How many feet are they able to walk without having to take rest breaks? So on and so forth. Maintenance therapy is something a lot of agencies don't do a whole lot anymore, so I'm not going to go in deep. But the biggest thing to remember here is that those maintenance therapy sessions have to be provided by a qualified therapist. So it can't be a PTA or a CODA or whatnot that does maintenance therapy. That has to be done by the physical therapist. So when we look strictly at physical therapy, what is included, what is considered skill? So skilled rehabilitation services concurrent with the management of a patient's care plan must include objective tests and measurements such as, but not limited to, range of motion, strength, balance, coordination, endurance, and functional ability. So all of those things should be listed in your assessment, your initial evaluation, and your reassessments for every patient. Therapeutic exercises are covered only if they are required to ensure the safety of the patient or the effectiveness of the treatment. So going out and providing education on that home exercise program is not considered billable unless one of those exercises, the patient's at a high risk for falling. And if that's the case, that has to be documented. If the patient is not performing the home exercise in an effective manner, that has to be documented in order to justify re-education and hands-on therapeutic exercises. Gait training. So gait training is definitely a skilled service, but they really want to see if you're having to focus on gait training that there's some sort of neurological, muscular, or skeletal abnormality. One of the biggest things here too is that you're documenting abnormalities in the gait. So, what's their stride, their heel to toe, what kind of gait abnormalities are you seeing? Those have to be documented. Distance of ambulation should be considered as relational to homebound status. So this is where we get a lot of kickback when patients are ambulating more than 200 feet. Most places, if you can ambulate 200 feet, you should be able to leave the home. Now, things that, have to be taken into consideration here is how many steps do they have to go down to leave the home? Is it gravel that they're walking on? What is the situation? So again, all of that has to be documented. So if you are saying that, you have a goal of the patient ambulating 300 feet, why? Is it 300 feet in order for the patient to exit the home or the building? Do they have to walk 300 feet in order to get to the dining room? If you're, when you're setting your goals for ambulation when it comes to feet, you need to be addressing, why? What function or what ADL is the patient attempting to do that requires them to walk this amount? Or is it simply, just to be mobile around the home? If it is, then do they really need a goal of 200 feet? Probably not. So make sure when you're writing those ambulation goals that you're including, what the true outcome is. You want that patient to be able to attend meals. That patient needs to walk this amount of feet in order to exit the building. The patient needs to walk this many feet in order to get to the bathroom. What are you trying to accomplish? There's a couple examples here for physical therapy. Range of motion. Only a qualified physical therapist may perform range of motion tests, and therefore such tests are skilled physical therapy. So if you go out and you're doing specific range of motion tests, that could be considered a skill. Range of motion exercise constitute physical therapy only if they are part of an active treatment for a specific disease state, illness, or injury. So you cannot have a plan of care for range of motion unless you're treating something specific. So whether that's a hip replacement, a shoulder replacement, a fractured elbow, I don't know, but it has to be related to some sort of specific disease, injury, or illness, and what that specific disease, injury, or illness is must be reflected in your documentation. Passive exercises to maintain range of motion, such as in paralyzed extremities, can be carried out by unskilled persons and do not constitute skilled physical therapy. Some other skilled services are listed here: ultrasound, infrared treatments, whirlpool baths. All of that, is hit and miss on whether our in-home therapists have the capability of doing some of that. But basically, those can be considered skills. just have to have the appropriate documentation to go along with it as far as why it's required, what you're treating with ultrasound, how long you're leaving hot packs on and why that's indicated, so on and so forth. Physical therapists can also provide wound care within their scope of practice. Speech therapy assessments should include any causal factors and the severity of the speech and language disorder, as well as the rehabilitation potential. So make sure that when our speech therapists are documenting on their evaluations, they're including that. Reevaluation would be considered reasonable and necessary only if the patient exhibited the following things: a change in functional speech or motivation, clearing of confusion, or a remission of some other type of medical condition. So some skilled ST services would include speech or voice disorders that are a result of an injury or an illness, to establish speech, voice, language communication tasks and cueing that helps with a speech or language communication deficit, to train the patient, family, or caregivers in ways to augment the speech language communication or treatment, to assist patients with a diagnosis of aphasia in relation to their speech and language skills, and to assist patients with voice disorders to help develop proper control of the vocal and respiratory systems in order for voice production. Those are the skills outlined in the Medicare benefit policy for skilled speech therapy services. Occupational therapy, again, the big thing that I want to point out here is we need to see objective assessments of function. We need to be able to see a comparison of those assessments when we are talking about progress of the goals that are established. So some skilled OT services are task-oriented therapeutic activities. So those are designed to restore physical function. The example here, using woodworking activities in order to help restore shoulder, elbow, and wrist range of motion deficits. To restore sensory or integrative function. So the example here is providing motor and tactile activities in order to increase sensory output and improve response of a stroke patient. Planning, implementing, and supervising a therapeutic activities as part of an active treatment program for psychiatric illness. So this could be the use of sewing activities that require following a pattern in order to help reduce confusion and restore reality of a schizophrenic patient. Teaching compensatory techniques to improve activities of daily living. Designing, fabricating, and fitting of orthotics and self-help devices, and vocational and pre-vocational assessment and training, which is directed towards the restoration of function in ADLs that were lost due to an illness or injury. Again, one example here of an OT. Home health aid, big thing here is you need to make sure that hands-on personal care is being provided. Now, when we talk about hands-on personal care, there's quite a few things listed here. Bathing, dressing, grooming, some things I didn't think of. Changing the bed linens of an incontinent patient would be considered personal care. Now, can we send a home health aide out just to do that? I mean, you could be doing that 5 times a day. No, there has to be something along with it, but you have to show that hands-on personal care is being provided. Assisting with elimination, which can include enemas if the home health aide is approved to do that and is checked off to do that. And then the home health aide can also assist with ambulation, changing position in bed, and assistance with transfers. They can perform simple dressing changes that don't require the skills of a nurse. They can assist with medications that are ordinarily self-administered. So that may be providing the patient a reminder, that can be handing them their pill box, but they cannot administer those medicines. Assistance with activities that are directly supportive of therapy. So if the therapist comes out and teaches the home health aide some passive range of motion on that paralyzed patient, they can assist with those type of activities. We've got an example or two here for home health aide. Medical social services includes assessment of the social and emotional factors that are related to the patient's illness, the need for care, their response to treatment, and any adjustments to care. So when we're looking at an MSW assessment, we should see assessment of the home situation, financial resources, and the availability of community resources. Now, one of the skills could be to assist the patient in obtaining available community resources, but they have an exclusion here. They do not cover the services of a social worker to complete or assist in the completion of a Medicaid application. So that cannot be the skill that that social worker is going out to do. Can they assist them at that time if they actually have another billable skill? Yes, but that cannot be the sole purpose of sending out a social worker, is to help with a Medicaid application. Counseling services that are required, social workers can provide that. Another big thing that a lot of people don't think of is social workers are intended to help remove clear and direct impediments to effective treatment. So that can be something as, brief intervention from a social worker to help correct a behavior, to assist with family members or caregiver issues that are obstructing care, or prevent the patient medical treatment. Social services to address general problems that don't clearly and directly impede treatment or recovery are not considered a billable skill for an MSW. Got a couple examples here for MSW, and our last thing we're going to look through is medical supplies. So the home health agency is required to provide medical supplies for a patient which has a condition that is related to a chronic condition and requires the medical supply. So you have to have physician orders in the plan of care that reflects all of those non-routine medical supplies provided. Now, everybody needs to understand the difference between routine and non-routine supplies. Routine supplies are considered routine because they're used in small quantities for patients during the usual course of most home visits. So I've highlighted some of the most common ones: alcohol pads, tape, gauze pads or 4x4s, non-sterile gloves, specimen containers, incontinence briefs or chucks if those are being used by the caregiver or used by the nurse or the home health aide in order to provide care. So, if you have to have a chucks when you're washing a patient's hair in the bed, then that chucks is considered a routine supply. Also also includes thermometers, tongue depressors, and probe covers. Non-routine supplies are labeled so because they're needed to treat a patient's specific illness or injury. So these are patient-specific supplies. Again, those have to be placed on the plan of care in order to charge for them. This item has to be directly identifiable to an individual patient. Now, these are billed separately from the general payment or the episodic payment of a Medicare claim. That's why they have to be on the plan of care. They have to be ordered and specifically identified. So examples of non-routine supplies would be specific dressings for wound care, Telfa pads, Kerlex, sterile solutions, sterile gloves, any IV supplies, ostomy supplies or patient-specific, Foley catheters, drainage bags and irrigation trays, enemas, syringes and needles, and any home testing as far as the blood glucose monitoring strips, your INR strips, urine monitoring strips. All of those can be billed separately for that patient. So we need to make sure those are getting on the plan of care as an order, and that you also are documenting within your record that you have used those supplies so that we can bill those out separately. All right, that is all I have. I tried to get through that as quickly as possible. Again, all of this information came straight out of the Medicare benefit policy. Here is a link to the CMS website where you can look at that information yourself. Again, I would recommend printing out the outline for this and keeping the pieces that you can use on a regular basis to assist you in documentation. But it's imperative that we start documenting based off of the medical necessity for these services. So remember that each visit, whether that be nursing, therapy, home health aider, and MSW, has to document what skilled service was provided during that visit. So hopefully this webinar will help to identify what those skilled services are so that we can see better documentation and ensure payment for the services that are being provided. Again, if you have any questions, feel free to reach out to me. I'm available anytime. And I hope this was somewhat helpful for everybody. Thank you.